So it's 7 o'clock and we thought we would get started. I know Dr. Severin, you wanted to say a few words first.
Yes, I just first of all wanted to thank you all for attending our second ever virtual educational meeting. And we've gotten a lot of good response to this format, so we may keep it virtual for a little while before we return to the office, although we're open to your suggestions. If you certainly would prefer to be at the office and have the sangria and the Mexican food that we're famous for, we can always make that happen. But it's been a while since we've done one of these, and it has been an interesting time for everybody, as I'm sure you are all aware. Things at the office have been going along pretty well, and there's a few things that I just wanted to update you on before I turn the floor over to Dr. Adele today. First of all, many of you may know, but we have opened up our first satellite office. It's in Brentwood. It's in the downtown area of Brentwood, and we are taking consultations there for cornea, cataract, general ophthalmology, as well as glaucoma, of course. And so far the office has been doing great. I love going there personally. It's just a quieter space in the San Ramon office, so I really enjoy it. So just know that we do have the Brentwood office up and running, and that's been going very well for us. At the same time, in the midst of the pandemic, we also were successfully able to open up the Research Institute, which is right next door to our main office, up on the second floor of 5801 at the hospital. And of course, during the pandemic, we couldn't use it for the research that we had intended, but it still worked for us. We were able to move our diagnostics over there, and then we used the back half of the office space as a distance learning center for the children of our employees. And we had hired a full-time tutor to work with them. So we had 5 children who attended an entire year of school at the East Bay Eye Center Academy. And Dr. Adele and I did a graduation ceremony for them just 2 weeks ago as they finished off their year. But now that that's under control, we finally have the Research Institute doing what it's supposed to be doing. And on the glaucoma front, we have 2 big studies going on right now, which are all based upon glaucoma diagnostics. And at the same time, Dr. Adele has 2 big studies going on that she's doing. One is a dry eye study, which is looking at CEQA in patients that have failed Restasis. And then there's a big study coming up on Demodex, which Dr. Adele can talk to you about if you want, but both of these are studies which are open to enrollment. So if you have patients with blepharitis or dry eye, they can get paid, and there's some good work that's being done at the Eye Research Institute. Perhaps the biggest news that we have to tell you is that starting in September, we will have the new associate, the 3rd associate, joining our practice. And this is Dr. Rahul Raghu, who is a glaucoma specialist. He's a UC Berkeley grad, where he studied molecular biology with an emphasis in neurobiology. He then got an MBA in healthcare management at Brandeis University before going to medical school, where he went to the Albany College, Medical College in New York. He was Alpha Mega Alpha there, National Honor Society, went on to do his ophthalmology residency at Case Western Reserve in Cleveland, Ohio, before going over to the world-renowned Wills Eye Hospital, where he's just finished his glaucoma fellowship. I believe that the moving company was at his house this morning, picking up his stuff. His wife is starting a fellowship in Stanford in pediatric emergency room care. So they're moving the whole family out here. And we're looking forward to having him join us. So he's going to be joining and helping us with the glaucoma load, which has really become quite large at the practice. So starting in September, you'll be able to make referrals directly to Dr. Raghu, and we will be having him joining us for one of our future video conferences. So you'll have a chance to meet him, and we'll have him educate all of us. But he'll be doing cataracts as well as glaucoma for us. And then the final thing I wanted to talk about before we move forward with Dr. Adele's lecture is one of the things that came out of the whole pandemic and the concept of the virtual medicine, which took on a bigger and bigger role for many of us, was something that Dr. Adele and I were playing around with. And that is, we know that sometimes you have patients that you want to ask questions about, and you might hesitate to call us because you don't want to interfere, you don't want to take a time, you don't have the time, whatever the situation may be. Dr. Adele and I were considering starting a time where we can plan in the normal workday to do virtual one-on-one doctor consultations with you. So you might have a patient in your practice that you just want to run a few things by. Maybe you want to show a visual field test, you want to show a topography, you want to get our opinions on it, but maybe you're not sure it needs a full consultation. if you guys are interested, and if you tell us that you're interested, we think we're going to be starting this program of virtual one-on-one doctor conferences where we can just meet like this for a brief period of time and talk about whatever patients you might have on your desk. And then we can decide if they need consultations or not. Anyways, it's enough about me. You didn't come to see me. I'd like to turn this over to Dr. Amy Adele. Most of you know her by now. She's been with us for 7 years, 6-ish-esque.
Feels like
She's been a wonderful associate, and I don't think I could have kept the practice going through COVID without her help and her diligent work ethic. Amy did her medical school at Dartmouth, where she then went on to do her residency at New York University. She finished her cornea fellowship at the Tufts University in Boston, working with the ophthalmic consultants of Boston. And I turn it now over to Dr. Adele.
All right, well, thank you very much. I'm very happy to be here, and thank you. Wow, we're at 114 attendees. That's just fantastic. I'm pumped to start talking to you guys about what we have to talk about tonight, which is COVID and ocular manifestations. So I'm going to attempt to share my screen here. Bear with me. And you should be seeing very shortly my presentation coming up here. Okay. All right, can you just give me a thumbs up in the chat if you can see my presentation here? Is it looking good for everyone?
I can see it, Amy.
Okay, I'm gonna go full screen here, so I'm not gonna be able to monitor the chat. If anyone has a burning question during my presentation, I do welcome you to type it in the chat. Dr. Severin will be looking at that here and now and then. And if there's a question, feel free to interrupt me, Dr. Severin, because I think it's most useful when people can get their questions kind of addressed as they think of them. But I will also leave time for questions at the end. So we're going to talk today about the coronavirus 2, also known as the virus that causes COVID-19, and ocular complications and implications. So first off, some disclosures. I prepared this independently by myself, this lecture, without input from any commercial interest. And I do have no relevant financial relationships to disclose. Briefly, just a couple words of intro. Dr. Severin did a great job introducing me. For those of you who don't know me, I joined East Bay Eye Center in 2015 as a cornea, cataract, and anterior segment specialist. I do see patients in our San Ramon and Brentwood offices, and when I'm not in the office, this picture right here is usually what I see, bringing up the rear on a family hiking trip around our beautiful hills in the East Bay. So just to set the stage here, the current state of the pandemic. If you had told me back in December 2019 that I would be giving a lecture halfway through 2021 about COVID, I would not have believed you, but here we are. So in the United States, there's been over 34 million confirmed infections with a very well publicized over 600,000 deaths at this point. Globally, there's been about 177 million cases with 3.8 million deaths. Almost 2.5 billion vaccine doses have been administered. So this includes both single dose vaccines and vaccines that require a booster. But despite this, cases are still increasing in parts of the world. So Russia, parts of the UK, South America, Indonesia, and Africa are currently facing increasing cases that are out of control. So our focus for today, I want to give a little background on coronavirus itself. When preparing this talk, we've just been living it day to day. And so it was nice to kind of go back to the basic science and just refresh my memory on the coronavirus itself as a proper medical scientist should. I also wanted to give some brief updates, things you may be hearing in the news or things that patients may be asking you about. Also wanted to touch on risks specifically for eye care professionals, as well as risk mitigation techniques that we should all be using in our offices still. And also go over some ocular symptoms and signs of that can show up in patients with COVID-19 and try to give you a sense of how common they are so that you can look out for them. And then at the end, where do we go from here? So jumping right into it, going back to the basic science just for a few minutes here. So coronavirus has increasing prominence on the world stage. We're all remember the SARS epidemic in 2003, which fortunately didn't affect our shores too much. It was kind of something that was over there, didn't really come to the United States in a huge fashion. Then there was the Middle Eastern Respiratory Syndrome virus in 2012, and then a variant of the coronavirus that is 80% similar to the original SARS from 2003, which is the second covariant, also known as COVID-19. It's a single-stranded RNA virus, which makes its replication very efficient. It can be directly translated from the RNA that's encapsulated into viral proteins. There are 7 of these viruses in this family known to infect humans, and they usually infect humans with their spike protein on the outside. So in this picture, that's the famous spike protein all around the outside of the capsid there, which connects to the ACE2 receptor on our cells, and that's how the infection occurs. So the ACE2 receptor is very important. It's critical for infection. It's expressed on lung epithelial cells, which explains most of the respiratory predominance of respiratory problems with this infection. But interestingly, it's also expressed in the aqueous humor and retina. And I was just reading a paper that did not make it into this talk, but limbal stem cells in the cornea actually can express ACE2 and can be infected by coronavirus. So that could be a potential mode of infection right at the limbal stem cells. So an overview on how the infection occurs, it actually occurs with 2 main mechanisms. So the first could be endocytosis, where the viral particle attaches to the ACE2 receptor and then is kind of swallowed up by the cell, taken into a vesicle, and then the virus breaks free of the vesicle. The RNA uses the host machinery to make the viral proteins. And then you also have membrane fusion, which needs this co-receptor, the little purple crescent there, the TMPRSS2 co-receptor along with ACE. When those are both triggered, it causes the virus, it's actually even more efficient, is able to just insert its RNA right into the cell directly. So those are the 2 mechanisms of actual cellular infection. So I want to talk a little bit about this number called R0. It's their basic reproduction number, and it helps us get a sense of how infectious COVID-19 is versus other diseases we are more familiar with. So for the number represents the number of people that are expected to be infected from one person who has the disease. So for COVID-19, it's going to be around 1.4 to 6.49. Slightly more than flu on the lower range of that. And then of course, measles is extremely famous for being one of the most contagious diseases out there, and it's airborne. So you just need a tiny amount of the virus to get infected, and one person on average transmits it to 12 to 18 people. So measles is pretty terrible on that front. When we get to talking about some of the newer variants that have emerged, you know, these numbers may be revised up, I'm not sure, closer to the 6 range, but I haven't seen any data on that yet. I just don't think we know yet. So in terms of replication of the virus, this occurs on the mucosal epithelium in the respiratory tract, starts in the upper, goes to the lower respiratory tract. And infectiousness starts 2 days prior to symptom onset, or it can begin then, and it peaks right before symptom onset. And so very kind of devastating with coronavirus infection is that about half of transmission occurs before symptoms occur. And so this, combined with the fact that it's as easily spread as an upper respiratory infection, like just a common cold, is, I think all those factors together help explain why this has become such a disaster, such a catastrophe on a global scale. We all know that the infection is spread by respiratory droplets or even aerosols, which are tiny particles under the right conditions. And so I wanted to go on to some breaking news. So we've all heard about this Delta variant. So it was formerly known as the scientific number. I like Delta variant much better. It was originally identified in India, and it now makes up 90% of cases of COVID-19 in India and the UK. It first came to the US in March, so it's here, and it now accounts for 20% of COVID cases in the US. And the next slide, I have a bar graph that shows the increasing part of the COVID pie that is this variant. So take a step back and remember that UK variant that emerged, and that was thought to be 60% more transmissible than original COVID. Well, the Delta variant is thought to be 2.5 more times transmissible than the original COVID strain. And when the UK variant showed up, it only took 5 months for it to become the dominant strain in the United States. And so the Delta variant is close to following in the UK variant's footsteps. And so I would not be surprised if the Delta variant becomes a dominant strain very soon, in a matter of weeks here. The good news is that the vaccines are effective against this variant, so very highly effective if you've been fully vaccinated. However, for the double dose vaccine, so the Pfizer and the Moderna that we have commonly here, after 1 dose of the vaccine, you're only 33% protected from the Delta variant. That is serious. So we need to look at that. And of course, we need to increase vaccination rates among our population in addition to social distancing when appropriate and masking and that kind of thing. And that's how we're going to stop this pandemic. And we'll talk about that a little more later. So here's a graph. On the bottom axis, these bars start in late March. This is numbers from the US, and every bar represents the numbers over the next 2 weeks after. And so the different colors on the bar indicate the different variants. And I've circled this orange bar, and this data was from June 19th. So if you rewind back, if you look back to the March bar graph, that very first bar graph, the slice that is the Delta variant is so small, it doesn't even show up. And so just in a matter of several weeks, it's become, there you see in the table, about 20% of all COVID infections in the US. So it is growing. And if you just look at the trend, it's going to probably continue to grow. That's what it's done in other places where it's been present, and we're really no different. So switching gears here to risk mitigation, patients and staff. And what I was going to say, Dr. Severin, is when I'm in full view here, I can't see the chat. So if you think there's a good question that I should answer right away, feel free to just jump in and interrupt.
I sure will.
Great, thank you. So I wanted to spend just a few minutes on risk mitigation for patients and staff. I know we're all very familiar with this already, but I wanted to go and start here with, these pictures just kind of underline the tragedy. This is Dr. Li Wenliang. He was an ophthalmologist at Wuhan Central Hospital in China. Widely credited with being a whistleblower. He was noticing groups of pneumonia in December of 2019. And he unfortunately succumbed to COVID disease. And it's thought that he may have gotten infected on a routine pressure check for a glaucoma patient. So we're on the front lines in a sense, because we're close to patients and we see a lot of patients. And so I just wanted to start with his picture because he tried to sound the alarm about what was going on. So as I mentioned earlier, we have high volume clinics. We are close to our patients. We have equipment heavy offices with lots of touch points. We come in contact with patients' mucous membranes. If you're using non-contact tonometry that generates aerosols, that could be an infection risk. So there are several elements that are specific to eye care practitioners, and we should be aware of all of these so that we can protect ourselves, our patients, and our staff and our families. So a note on the easing of restrictions. So the CDC and California have come out easing some COVID restrictions. If you're fully vaccinated, you don't need to wear a mask in certain settings. Importantly, these do not apply to healthcare settings. So especially since we see vulnerable patient populations, we should be continuing to keep up all of our infection measures for the time being. Patients are coming to us for medical care, and they deserve to be safe. So I know there is such a thing as COVID fatigue, but it is our obligation to do what's appropriate, and this is what's appropriate at this time. So a couple things that we do at our office, and some of these we may continue to do, we try to identify high risk, which would be sick patients, before they come to an appointment. I think a lot of patients know at this point it's just common sense. You don't come in if you're sick. But if we are reaching out to, say, confirm an appointment, we will go over that and say, you know, please don't come if you're ill. We'll reschedule your appointment. Are you feeling ill now? That kind of thing. Masks. So if I have a couple picture of different kinds of masks here. Healthcare providers should be wearing either an N95 or similar, or a surgical mask. They have been shown to be superior to even multi-layer reusable cotton masks. N95 masks have been hard to come by sometimes. There are studies of influenza virus that show that if the provider and the patient are both wearing a medical surgical mask, the effective protection is similar to an N95 mask. The other thing about N95 or K95 masks is they really aren't working if they're loose, if they're not sealed. And so to have it actually be sealed and be working as a proper N95 mask, they're incredibly uncomfortable. They're just very, very tight. So if you're wearing an N95 mask, but it's comfortable, that means it's probably too loose and you're really not getting the protection that it's worth. And it's better to go with a medical mask and have your patient's mask up as well. And you'll be getting good protection that way. Okay, so the physical plant, our actual offices ourselves. I'll just briefly go over this. I think everybody is familiar with these things. Social distancing, disinfection of surfaces, upgrade the ventilation. I thought it was interesting that mitigating the mitigating effects of updating ventilation. So at our offices, we have air purifiers in every room. And so if you do that properly, you could have a mitigating effect comparable to vaccination rates of 50 to 60%, which is pretty good. Breath shields, we have breath shields on every slit lamp. I'm constantly smacking into them because I'm still not used to them. But they are good. They protect us. They really should be cleaned properly between patients though, because they can get contaminated and then you're just actually maybe harming instead of helping by having the shield in place. So now to the meat of it, the ocular signs and symptoms of COVID-19 disease. And so I'm going to take you on a whirlwind tour of the literature of what has been reported to be associated with COVID-19. And it's not a really exactly clear picture because a lot of it is case reports. There have been some reviews and meta-analyses that put a lot of these case reports together and kind of tabulate the numbers. But for reasons we'll discuss, we still don't have an exact picture of everything that COVID-19 can do, but it tends to do things that other viruses do to the eyes. So for COVID-19 disease, the most common symptoms we know: fever, dry cough, dyspnea, myalgias, headache, diarrhea. Most patients have mild symptoms. These symptoms are all pretty nonspecific, except for the anosmia and ageusia, which is such a great word, lack of taste, loss of the sense of taste. There has been some insight into what causes these two symptoms, which are pretty specific for COVID-19. I was reading reports of brain scans showing atrophy in some of the areas that control taste and smell. So I think we're just at the tip of the iceberg here on where exactly this disease affects what structures. So patients with COVID-19 will often have derangements in their labs, in their white blood cell count. They'll have elevated non-specific inflammatory markers in their blood, and very sick patients tend to be hypercoagulable. There are these very pathognomonic ground glass opacities and bilateral patchy shadows on CT of the lung. And death from COVID-19 most commonly results from the cytokine storm, which is similar to how people ultimately succumb to sepsis when there's an infection, and rather than the actual infection killing you, it's the body's own response that's out of proportion, that goes a little bit haywire, and then ultimately the vasculature can't support the blood pressure, and there's end organ damage, and then there's no coming back from that once you pass a certain stage. So the average range of from symptoms to death is 6 to 41 days, with a median of 14 days. And the risk factors for complications are patients with cardiovascular disease, hypertension, diabetes, and obesity. So when you get to ocular involvement, the waters are a little bit muddy in terms of what's really going on. How common is a certain finding in a certain patient that has the disease? The timing of testing. So remember how patients are most infectious in 2 days before symptoms or right at the onset of symptoms. And rarely are we catching patients before they have symptoms or right the day of or the hour that they're having symptoms. So oftentimes we're going to be testing too late in terms of actually testing the conjunctiva to seeing if tears are actually transmitting the disease. So it looks like, I remember in the beginning, there was a lot of question about, can tears transmit the infection, transmit the virus? And it looks like only in patients with active conjunctivitis are the ones that we're able to retrieve useful virus from on culture. There have been 2 studies I'm aware of COVID patients who had using either conjunctival test paper or Schirmer's serial day by day, checking their tears for the virus, and they were negative. However, in patients who had conjunctivitis, but no respiratory symptoms, their conjunctiva were positive for the virus. So it really does look like if the eyes are white and quiet, there's not likely to be infectious virus there. So the rates that I'm going to quote may be falsely low. As I mentioned before, we tend to collect samples later in the disease course. And as far as I can tell, the largest study I've seen is 121 COVID positive patients. And there was a positivity rate for conjunctival swabs of 2.5%. So that's probably maybe 2.5% or thereabouts of patients who have the disease have actual infectious virus particles on their ocular surface. And we should know this because we're examining these patients. Calcium alginate swabs, I don't know if anybody uses these. I use them sometimes to culture the cornea, but they can deactivate virus. And so they should not be used to collect samples, excuse me. And probably the highest sensitivity test is going to be a PCR test from the conjunctiva. Same PCR test that you get the nasopharyngeal swab could be used from the conjunctiva. So how could one either become infected or transmit the virus from their eyes, essentially? There are a couple theories about this. So if you have the virus infection in your respiratory tract, it is possible that the nasolacrimal system could act as a conduit for that virus to get out onto your ocular surface. That may be how the virus becomes present in tears in the first place. And on the receiving side, the conjunctival epithelium is directly exposed to the environment, and virus particles that land on the ocular surface could then be transmitted down into the nose, into the nasopharynx, and cause infection that way and enter the respiratory tract. So coming up are a few studies I have found. They're mostly case reports. There's one that's a big review. It probably gives the most accurate sense of the numbers here. But this was a case series from Hubei province in China of 38 patients. So only one patient presented with actual conjunctivitis, but 31% had conjunctival hyperemia, chemosis, epiphora, and increased secretions during their illness. Now, that kind of sounds like conjunctivitis to me. I mean, maybe I'm being too general about it, but I think the rate of some kind of conjunctivitis could probably be up to 31% based on this. So this review by Sen and the co-authors here, this is the largest that I'm aware of, where they looked at several different case reports and put everything together. And on the bottom, you have this table. So I think this is probably the most accurate we're going to get. Discharge, redness, foreign body sensation, itchiness, lid margin hyperemia, chemosis, MGD abnormality, crusted eyelashes. What do these things all have in common? Well, they're very non-specific. They could be anything. So I think that when you're thinking about what COVID can do to the eye and what we are likely to see in our practices, it's going to look like viral conjunctivitis. It can do a lot more than that, and we'll talk about that, but it could have all of these features. This was another study about sore eyes. So sore eyes were found to be the most significant symptom in patients that were experiencing COVID-19. So there were 83 participants here, and 20% had photophobia, sore eyes, or itchy eyes. I don't know about you guys, but if a patient came in telling me that they had sore eyes, the very first thing I would do would be, tell me what you mean by that. What does that mean? Are your eyes gritty? Are they burning? You know, I don't really know what sore eyes means, but that's how patients described it. So that, just file that away in the back of your mind. Maybe that's how patients experience it, and that those words may come up. And so just remember that and think twice about it if someone's talking about their sore eyes. So interestingly, most of the symptoms occurred within 2 weeks of other COVID symptoms and lasted less than 2 weeks. So this is a similar time course for something like a regular adenoviral conjunctivitis that maybe peaks 7 to 10 days and then is over by day 14 generally, or sooner in a lot of cases. This one I came across it took me back to my days during the pandemic when we were doing a lot of telemedicine. And this patient actually presented with unilateral conjunctivitis and then developed respiratory symptoms and then was tested for COVID and was found to be positive. So it is the case that conjunctivitis can be the first presenting sign of COVID-19 in a patient. So if you see someone like this, let them know. If you start getting sick later, you should probably get tested for COVID. So the take-home points for the anterior segment are going to be that conjunctivitis is very well documented in the literature. It can be the only presenting sign of COVID-19, and the incidence with COVID-19 infection ranges wildly. Up to 1/3 of patients may have some form of conjunctivitis. So you want to, if you see a patient with conjunctivitis, anybody like this, don't forget to look for pseudodendrites, subepithelial infiltrates on the cornea, or epithelial defects. And although it is actually pretty rare for keratitis to cause endophthalmitis, there were a cluster of cases in New York of patients who had COVID, who also had keratitis leading to endophthalmitis, but they had secondary bacterial infection, which was probably the true etiology of both the cornea and the endophthalmitis infections. So in two sentences, consider having your patient tested for COVID if they have a viral conjunctivitis picture and some of the COVID symptoms like fever, cough, all those things. Culturing the conjunctiva may be low yield, and I just don't think that it's really worth it. If the patient is sick, go have them get a real COVID test. You're more likely to catch something than you are with a standard conjunctival culture. If you want to send for PCR, that could be positive. It's probably also going to be really expensive and just, I think, unnecessary if you can just get a free COVID test. So moving to the posterior segment. So there are a number of different findings here that have been reported. There's this hyperreflexive lesions at the ganglion cell and inner plexiform layer, cotton wool spots, and the mean duration and little hemorrhages. The mean duration between the symptoms and the signs was 12 days. So for these posterior segment signs, they tend to occur, the pattern is they tend to occur a little bit later in the course of the disease, whereas the anterior segment ocular surface symptoms are usually either before symptoms or right around the onset of symptoms. So the timing's a little bit different from the front of the eye to the back of the eye. So more posterior segment findings, and these are all pictures taken from patients with COVID-19. So you can have artery and vein occlusions, vitritis, acute retinal necrosis, which is usually something we think about with the herpes viral infections. You can have retinal hemorrhages anywhere, peripheral or central. You can have flame hemorrhages around the nerve, neuroretinitis, hard exudates from all the fluid that's extravasated from the blood vessels, cotton wool spots. But you have to take this with a grain of salt because these are the really sick patients. A lot of them were in the ICU in some of these studies, and they had a lot of other reasons other than just direct COVID infection to have these. With hemodynamic instability, a lot of them were on anticoagulation. So it's a little bit of a mixed bag here, but this is what the literature shows. These are the findings that have been reported. So moving on to neuro-ophthalmic findings, papillophlebitis, bilateral optic neuritis, 80s tonic pupil, and cranial nerve palsies. So it really looks like it could do anything. That's how I kind of think of the herpes viruses, and now I'm starting to think of coronaviruses as similar. Moving on to orbital involvement. So this is more for patients who have moderate to severe disease. So most of the patients who are going to have orbital findings are the really a lot sicker patients. Dacryoadenitis, retroorbital pain, orbital cellulitis, sinusitis, and then rhinoorbital mucormycosis, which I wanted to expand a little bit on. So I don't know if you've been alive in the past couple of weeks, you probably heard about this thing called black fungus in the news. And the actual disease is called mucormycosis. It's an aggressive and opportunistic fungus that likes to infect the lungs and the rhinoorbital tract, as well as the GI tract. The theme with this infection is the blood sugar is up, and that increases your risk of getting infected. So diabetic patients are by far the most likely to have to deal with this infection. A lot of the cases in India that are being reported are patients who had diabetes either before COVID or suffered organ damage and got diabetes afterwards. There's some other kind of immunosuppressed patients and people with hematologic malignancies and chronic steroid use, but diabetic patients are the most commonly described population who get this. I wanted to show you the picture. So this H&E stain, the top left corner, typically, and on all the board tests, you see this non-septate hyphae that branches at 90 degrees. That is pathognomonic for this organism. There's a characteristic blackening of the hard palate on the top of the mouth. So if you ever are unfortunate enough to see that sign, you may be dealing with mucormycosis, especially if your patient has diabetes, and they would need treatment, of course, right away. And then, unfortunately, this other patient here in the smaller picture has developed orbital involvement, and there have been quite a few enucleations, exenterations of patients in India right now because they just cannot control the infection. And the reason it's so hard to control is because the organism shows angioinvasion. So it goes into the blood vessels and makes them disorganized. It breaks up the blood vessels, causes the tissues to die. And then most of the antifungals are given intravenously. And if the vessels are toast, there's really poor penetration of the antifungal medication to the tissue, to the infected tissue. So a lot of these need to actually be mechanically debrided because they're so difficult to treat. Hyperbaric oxygen is also a treatment modality. It's very expensive. It's hard to come by. It's just not going to be available to a lot of the patients, especially right now in India, who are dealing with this. And one of the reasons why we may be hearing about this now in relation to COVID-19, and especially in India, is for a couple of reasons. So India is very hot and humid, so more likely to have fungal infections there, just like here in the US. We know that places like Florida and in the South, in the humid South, they have a lot of different fungal infections than we do in our dry climate. It's one good thing about being so dry up here. And patients who are real sick with COVID tend to be getting steroids. They get dexamethasone these days. And so that will increase the blood sugar, and that's linked to mucor infection. So in late May, this was declared an epidemic in India, and the mortality rate in India right now from this infection is just horrendous, at 50 to 90%, because it is just so difficult to treat, and there have been thousands of people losing their eyes and more due to this so-called black fungus. I never heard it called black fungus before the last few weeks, but there you have it. So here's a summary of the timing of the different ocular manifestations. So right here in this circle, that's where we are going to be most of the time. We are going to be seeing people who either, don't know they're sick yet, or are just feeling a little bit sick and they don't want to cancel their appointment. They're going to be the ones that are going to be showing up with the conjunctivitis and the episcleritis. And then you have the more deeper involvement of the cranial nerves and the orbital structures. Interestingly, blepharitis is way down there in the delayed one. I'm not quite sure how I could explain late onset blepharitis from a viral infection, but I'm open to learning if that ever becomes cleared up a little bit. So if you see a patient who you think has COVID conjunctivitis or COVID involvement with their eyes, the treatment is similar for conjunctivitis to regular viral conjunctivitis, just supportive care generally, lubrication, topical antibiotics to prevent secondary infection, not that the antibiotic is going to be treating the virus. I don't usually give antibiotics for people who have viral infections. There is some, there's my cat's trying to get in. There are some anecdotal reports that benzalkonium chloride, the BAK preservative in eye washes and eye drops, can have activity against some viruses. So if you just have the Rite Aid eye wash, it contains, I believe it's 0.01%. Oh my God, my cat. Is my cat too loud? Can you hear me? Well, hopefully you can hear me. I'll just talk a little bit louder. The BAK preservative in eye wash, you might want to rinse the patient's eye with that. It's not going to do them any harm. It's just regular eye wash. And then also 5% betadine wash could be effective against viral conjunctivitis. I don't know of anyone proving it against COVID specifically, but those are kind of optional adjunctive treatments that we could describe maybe in a later talk. For sterile corneal infiltrates, if they're present, you want to treat them with steroids. And then for vascular occlusions, you want to refer for medical workup to look at cardiovascular risks. If they're young, they could have a hypercoagulable condition or inflammatory or infectious. And then check if you ever see a vein occlusion, for example, that check the intraocular pressure, make sure it's not elevated. That's a risk factor. So moving on to what's next. So I think we are in for some interesting kind of public health situations. There have been studies showing that, for example, patients with diabetes had terrible control during the crisis and were not getting their sugar checked. I know that I do a lot of routine diabetic exams. Probably half of my patients, if not more, are not on target right now because they weren't getting their labs, they were stressed, they were home eating. So there's going to be a lot of public health problems that are only now not even being recognized, but they will be. Teleophthalmology, we forayed into that a little bit, and vaccinations I want to talk about a little bit. So vaccine hesitancy. So, some people understandably are hesitant to get the vaccine. And my opinion on this is that as a healthcare provider, we are obligated to show patients that we are in favor of vaccination. Okay, we don't have to force anybody and say you can't see us if you haven't been vaccinated, but we need to show them that we are in favor of vaccination. And motivational interviewing is actually a useful tool and has shown to be effective for talking to people who are hesitant about vaccines. I learned about motivational interviewing in medical school as a way to talk to people about quitting smoking. It's a way of kind of getting them to open up, and you don't actually really end up doing too much. They kind of figure it out for themselves. So this is something that I feel is really important. So I'm just going to spend a moment on it. And, you can think about this with your patients or people you come in contact with who are hesitant about the vaccine. So you start with an open-ended question, and you just say, what do you think about the vaccine, or what do you know about the vaccine? And you let them talk, and something may come up. They may either have an unfavorable or favorable idea of the vaccine, but you just let them start the conversation. You try to remain open. You show them that you're in favor of it. You can say, yeah, we got vaccinated and most of our staff is vaccinated, but don't make them feel bad about being hesitant. Just show them that you're open to the fact that they may not be quite ready to get it. And then ask their permission to give some new information to them. And you can talk about anything. You can talk about how the vaccine was developed, the science behind it. If you've had it, your personal experience or the side effects about, but don't just talk at them. It has to be solicited. So you have to ask them for permission to give them some more information, because if you just talk at them, then they may not really listen to you. But if they give you permission, that means they're in some way perceptive to what you have to say about this. Then you can ask them about the potential upsides. So this has to come from them. You can't just tell them, here, yeah, you can travel, you can do all these things. You can ask them, well, what would you be able to do if you got vaccinated? And they may know this deep down, and actually having them think about it and think about all the things that they could do if they were vaccinated, it may start to change their mind. And above all, just take it slow. You don't want to be bullying or pushing anybody because you're going to meet resistance. So you want them to know that you're happy to continue the conversation at another time, or offer, if they want to get in touch with you to talk about it. That's something that you can do. And this is for all of us. I think it's really important. I always find myself talking people into getting vaccinated against things. That's just my job, I guess. So take home points. It's unlikely that you have to worry too much about catching COVID from someone's tears. It's theoretically possible, and I would take extra precautions if the patient had active conjunctival inflammation. The yield on conjunctival cultures with swabs is very low. I wouldn't even bother myself unless it was a very special case and I was trying to prove something. I would personally send the patient, if I was suspecting it, for a standard PCR nasopharyngeal swab if I had a high index of suspicion. Keep in mind about the sore eyes and then the other non-specific symptoms. And don't forget to check for posterior involvement. If they have a really bad case of viral conjunctivitis, the presentation can vary and look like a lot of different things. So make sure you look in the back of the eye. All right, so what I'm going to do is stop sharing at this point, go back to myself, and thank you all for listening. Looks like we ended the talk in good time. Does anyone have questions? If you do, you could just type it in the screen there.
Dr. Adele, you do have one request to see the last slide again now that you've stopped sharing your screen.
I can do it. Not this one probably, but this one. Can you see that?
Not yet.
Oh, that's because I have to share my screen.
Why not?
Okay, so let's see here. Can you see it there?
Is that the one you wanted?
I think they said the last slide, so.
She says the previous one to that, I think. Is this it?
This is a good slide.
Yeah, you actually had a comment thanking you for talking about vaccine hesitancy.
Good. I think it's important.
And that was a slide that the doctor wanted to see.
Okay, perfect. Well, I wanted to shout out to, I heard we might have some students from the UC Berkeley School of Optometry attending. So if that's the case, thank you for being here. And you're all welcome to come to any of our talks, which reminds me that our next talk is going to be actually given by Dr. Severin himself. And he's going to talk about dropless glaucoma therapy, which I am very excited about, so that my patients don't have irritated eyes anymore from glaucoma drugs.
I'm your number one source of business.
Yeah, we're just such a great team.
Dr. Dell, you have a question?
Okay.
I've had a handful of patients who've had the sore eyes, in quotes, symptoms 2 to 3 months after recovery from COVID. Have you had any experience with this?
Not really, but it gets to my issue with the sore eyes categorization, which is I don't really know what that means. I'm always thinking about what is it so that I can help you. Is it sore eyes? Do they need can the person? I would ask if I would check out their refraction. I would look and see if they had any signs, uveitis, anything like that. This late onset blepharitis is rather interesting to me. I would look very carefully to see if they had any inflammation around their eyelids. I would look for a real source of pain, some kind of exam finding that would take me from the nebulous kind of sore eyes symptom to something focused that I could, offer an intervention for.
In this particular case, the doctor says that everything seemed quite normal on a comprehensive examination. And then there's a few other questions pending, but before we move on to the next one, with the sore eye syndrome, everything seemed quite normal and comprehensive check. Considering that there are known neurologic consequences of COVID, and I actually read a very interesting paper just, I believe, yesterday. You probably saw this as well, but they've done brain autopsies now on patients that have died of COVID, and they show that there's inflammatory markers inside of the brain, very suggestive of changes similar to what you can see in Alzheimer's disease. And it doesn't appear to be a direct viral infiltration of the brain. It's probably an inflammatory consequence, just like the cytokine storm is. Considering that there are no neurologic consequences, do you think that it's possible that there could be a neurologic induced pain to the eyes afterwards, just an oversensitivity?
It could be. I always try to think anatomically and think about, the nasociliary nerve is controlling the sensation around the eye, and it really should be on one side or the other rather than both. When people start to have bilateral pain, I start thinking more like sinus or tension headache rather than a real, ocular cause of that pain. But it could be, I'm sure it could be some kind of nebulous syndrome that is a real thing. That's the other thing. I always want to take the patient's complaint seriously, even if I don't know what it is yet, and I think that if patients know that you're willing to kind of follow them and stay with them until something, shows itself, I think they on the whole appreciate that, because sometimes patients present to you too early, and you can't really find anything yet. But if you stick with them and give them some ideas about things that they could do to help narrow things down, like a refraction, or use some tears, or a short course of a non-steroidal anti-inflammatory, you can kind of start knocking out things and try to get to the bottom of that persistent soreness.
You might have touched on it for this particular case. The doctor said that the symptoms sounded somewhat orbital to her, but still quite nonspecific. So that certainly could fall into the realm of a sinus issue. Do you know of any incidences of a inflammatory orbital syndrome that could happen after a viral infection of any sort?
Yeah, you can get idiopathic orbital inflammation related to viruses, and usually I would expect it to be more unilateral than bilateral, but
so maybe sinus in this case.
Yeah. That's what it sounds like to me.
You have another question. Dr. Wu was asking, have you heard from patients of any ocular side effects from vaccines?
Well, that's very interesting because, it's hard to comment on that really because it's kind of anecdotal at this point. But I was reading about, I was hearing of a couple colleagues who had a patient have a cranial nerve 4 palsy showing up after the vaccine. And wouldn't you know it, but later that day, I saw a patient who had a random cranial nerve 4 palsy and had the vaccine. So I wasn't sure if that was related. And by the time I saw the patient, it was already pretty much resolving. It was barely there at all. So that could be something. I think the biggest one that I have, I think, seen myself and I've heard many anecdotal reports of is inflammation triggered by the vaccine. So I've had colleagues who report rejection of corneal transplants
Oh, wow.
after the vaccine. A transplant that had been quiet for years and years, all of a sudden having a rejection episode. And then also uveitis triggered. So I had a patient of mine who I suspect had a flare of his HLA-B27 anterior uveitis because it happened right after the vaccine. It was within a few days of the vaccine, and it was the worst flare he's had since I've known him, and I've been treating him for years, and it was bilateral. So I do think that the response with the adjuvants in the vaccine, the inflammatory response is just so robust that it really does not surprise me that it could trigger for people who have a propensity for kind of autoimmune conditions and irregular immune activity, that it could trigger them. And I believe I have this one patient that had that.
Interesting. I was convinced in a number of patients, actually, probably more than 5, less than 10, who I happened to see within 24 to 36 hours of vaccines, who had previously been well controlled with glaucoma and all came in with significantly higher intraocular pressures and significantly higher, more than 20% higher. But it was only in patients who I saw immediately. If they were 2 weeks out, 3 weeks out, beyond that, it seemed to me that their pressures were all the same. And I could have been overcalling it. It could have just been 7 patients whose pressures were out of control. That's my life. But it was really quite striking to me that these patients, particularly because it was right when the vaccine was, I don't really ask patients now so much, like, when did you get the vaccine? Mm-hmm. I'm actually at the point where I assume a lot of our patients are vaccinated, although I do ask, but most of our patients have had it for a while now. But back in March, April, when patients were fresh, I was seeing patients coming in with higher pressures. I just didn't quite know what to make of that.
It's food for thought, a little trabeculitis or something going on there.
Absolutely. Well, I think that at this point, that's all the questions that we have in the chat room. Amy, that was a fantastic talk. Thank you. I learned a lot. We did get some positive response in there to continue to pursue the virtual doctor-to-doctor consultations. And what both Amy and I were planning on doing was basically taking an hour a week and scheduling time when we will be available to do nothing but doctor-to-doctor consultation. So it will be a time where you don't have to worry about pulling us out of patient care or what have you, or we won't be in surgery. It's time that's dedicated to that. And if you don't have a consultation for us, it means we get an hour of free time. We get lunch. So it's okay either way.
Yeah, I think that would be great, because I feel like I'd be happy to do that, and I think it's a great idea. If there's interest, we do it.
Yep. And we'll make Dr. Raoul give 2 hours because he's the new one. Yes.
Of course.
So, anyways, thank you all so much. I'm surprised that more than 130 of you stayed throughout this whole lecture, and we really do appreciate it. As we had said, we'll do another one, I think, in about 2 months. I think we're going to do one about every 2 months right now, unless you guys want this more. I have given a talk recently on the developments of dropless glaucoma therapy, and this does not mean surgery. These are things that will be applicable to all practitioners. Lots of new modalities that we can use to deliver medications that will be options for you to use in your office as well. So that'll be our next talk. And then I think we'll put Dr. Raoul under the spotlight and make him teach us something. Anyways, thank you, Amy. It was wonderful. Thank you all for attending. And we will get you contact to let you know when the next lecture will be.
All right, thanks everybody. We're going to sign out. Have a good
Thank you.
evening. Bye-bye.